Health. On this show, we'll have the opportunity to dive into case studies of population health in cardiology with 5 case studies with relating to gap analysis, gap closure, and care plans and care plan sharing with Dr. Furkan Tejani, who is our guest today. But first, let me welcome Dr. Brana Erdik again, our advisory board member and CMS go-to person for one of the states in the South. And he will help guide us today through updates, regulatory updates, starting with the public option in Colorado, amongst others. Welcome to the show, Dr. Erdik.
Thank you, Dr. JFL. As always, it's a pleasure to be here with you. I mean, it's been a really busy 2 weeks, right, with the Supreme Court rulings and everything. It's just there's a lot of moving things as always. So I'm gonna touch on one of the Supreme Court rulings, and it's not the one you think. So we'll get there. But first, as you said, the Colorado.
There are 2 Supreme Court rulings, by the way, but yeah, go ahead.
Well, there's 3 that directly tie into healthcare, but one of them I'm going to touch base on. The other one, I'm sure everyone has heard on the media. The third one is more about payments and Medicare Advantage, which is more administrative side of things.
Okay, go ahead, yes.
So the first thing is that it's amazing. So Colorado is the first state to have a public option. For those that don't know, a public option basically government-run healthcare as an option to private healthcare. So they have received Biden administration approval to create this public insurance. And ultimately, there was a federal waiver granted by CMS to use federal funds to set up this government-run health plan. So this has been, as you know, the dream and the goal of the Democratic Party for a while. And Colorado is the first state. This is called a Section 1332 Innovation Waiver, and it will be called Colorado Option. So hopefully starting next year in the state's Affordable Care Exchange, we will be seeing the public option. This is currently until 2027. Then it'll be reevaluated how it's doing, but hopefully it's gonna be good and it's here to stay. And off note, their premiums are expected to be about 25% lower, and it's expected to save the federal government about $215 million. And as you know, most of it is going to be with either chronic care management and management of chronic diseases and hospitalization and so on and so forth.
So tell us a little bit more. So this is for consumers, or you're talking about?
This is for consumers, correct. Okay. So let's say you're Dr. JFL, you're in between jobs, you don't want to keep the insurance of your previous employer, so you're going to go on Colorado Marketplace. Oh, there's a public option here now. So instead of buying insurance from Kaiser Permanente, you will be able to buy insurance that's government run and government paid.
Tell us about the prices. How much?
The prices are expected to be about 25% cheaper than other options. And then they are expecting the average price per month to be about $150.
So
and then it's gonna save the government money as well.
So this is for all Colorado residents are eligible.
This is all for all Colorado residents, correct? They are more than welcome to go on the Affordable Care Marketplace and then buy this option starting next year.
Very interesting. We can keep talking about this, but I'm sure you have other updates for us.
I do. So as I said, the Scotus ruling. So this one is about dialysis. Have you heard about this one?
Scotus ruling on dialysis. I haven't. Please.
So Scotus is the Supreme Court of the US for those of us that are not familiar with the abbreviation.
SCOTUS. I know POTUS, but yeah, SCOTUS.
Not POTUS, correct. SCOTUS.
Yes.
So basically, the justices said that the health plan could make dialysis providers out of network, as well as ultimately forcing these patients into Medicare. So they also refused to take the appeal by roundup. So 2 issues here is that, I mean, where's the limit now? Are the insurance companies gonna be able to reject providing dialysis or reject providing dialysis care to those that need it more than what they're providing? Because ultimately the hospital's defense was that it doesn't discriminate against patients with end-stage renal disease because it offers the same level of dialysis coverage for all patients. but all patients don't need dialysis. Only the patients with ESRD need dialysis. So what are
Yes.
they gonna say? Oh, we offer the same chemotherapy, just one cycle, but I don't need chemotherapy. If I had maybe breast cancer, I would need chemotherapy. So I
Yes.
think it's setting up the pathway for really interesting decisions down the line. One saving grace here is that, I mean, for those with end-stage renal disease, they qualify automatically for Medicare. So hopefully this patient's care won't be affected. But interestingly, the defendant on this court case was also DaVita. So
Okay.
DaVita argued that this patient needed more dialysis than what was being offered. So it's really interesting to me that a company that most people do not necessarily like or have bad impressions of
Mhm.
is out there trying to defend the patient's right to get more dialysis.
So, okay, just so it is crystal clear, it's very interesting. So we are talking about DaVita defending patient rights and not defending profit motive.
Correct. So basically, we're talking about DaVita versus an insurance company, and the insurance company saying, I don't have to provide this dialysis service because I only provide this many, and that applies to all patients. It doesn't matter if this patient has end-stage renal disease, and DaVita saying this patient has end-stage renal disease, they need more dialysis to live.
Well, I mean, if you're not getting a kidney, I mean, you'll need dialysis, right? I mean,
Correct.
so
That's
hospital,
why
yeah.
it is such an interesting and issueful finding, in my opinion, that I wanted to mention today.
So the hospitals being competitors, I mean, DaVita is outpatient, right? So they are
DaVita is mainly outpatient.
all,
Correct.
and how big are they? Do you know? Are they the biggest in the country?
DaVita and Fresenius are the top two. Correct.
Okay, so they are competing with hospitals to get the patient population.
Correct. So I think this creates a massive and inexplicable workaround to any insurance company back out of any benefit that they do not want to provide. They can just say we only provide this once, and that's the same for all patients.
Gotcha. Okay.
So it's gonna be interesting.
Okay, bottom line, prices wise.
Bottom line, price-wise, there may be a lot of things that are uncovered. It's not directly about prices, but let's say you need extensive chemotherapy and the company may say we only provide this once, and that's applicable to all patients without due regard that you have cancer and other patients don't have cancer.
And where does Medicaid fit in here?
I mean, Medicaid, correct. Medicare, you can qualify as an end-stage renal disease patient, but you necessarily don't have another automatic choice if you have any other sort of disease. So it's such an interesting and interesting finding, in my opinion.
So Supreme Court is red hot right now.
It is red hot, yes. Without getting political, I think this was even more so important than the other ones because once the ACA had done, was guaranteed that no one would be discriminated against based on their previous illnesses. No one would be restricted access to different medications, right? So this literally takes this ruling literally, in my opinion, takes the axe and guts the whole law in the middle because it literally creates an inexplicable carve out for any insurance company to deny any care they want.
Interesting. I mean, we can continue with that, but I know you have other things to tell us. Let's stick to the updates, and each one can go and dive and look up as per their wishes. Tell us about the third aspect of the third thing you wanted to bring up today, please.
So has been a lot of waivers, and some of them will start expiring. So I guess the most financially related is just the healthcare subsidies. So we're going to see higher prices and increased medical debt. So with the pandemic, the American Rescue Plan had enabled people to have lower healthcare insurance premiums and access as they're called, the premium tax benefits, regardless of income. So ultimately, there was 20% increase in the marketplace health insurance plans, and more people were able to afford these. So ultimately, some of these are going to be ending by the looks of it. So there is the chance that suddenly your patients as an outpatient in an outpatient setting or whatnot may be unable to afford insurance and may suddenly become uninsured. So as I've said before, with regards to Medicare and Medicaid patients, this time this is for privately insured patients. Now is the time that if you suspect that a patient has lost their job, may not be able to afford the insurance with the losing of the pandemic subsidies and the tax credits, is to reach out to them because they are at risk of losing that insurance, not being able to afford that insurance when the soft deadline, that is the Memorial Day, just like comes up to fruition.
What's the most relevant for physicians? Let's talk about
That's suddenly alongside some of your Medicare and Medicaid patients, some of your privately insured patients may be going uninsured. It's expected that up to 10 to 20% of patients will lose insurance in the upcoming months by the end of the year.
You mentioned that in the last podcast, so they have to look
Correct.
at state,
so
right?
that last podcast, that was specifically for Medicaid and Medicare. Now we are losing the healthcare marketplace subsidies and tax premiums as well. So this is particularly for people that have purchased that their insurance through the marketplace, like freelancers or other people that do contract work or that don't necessarily get healthcare insurance from their jobs.
What about for practicing physicians? What
They need
waivers are being affected?
They need to be aware that these people may lose insurance coverage, I guess. For a practicing physician perspective, the cross-state telemedicine waivers are about to expire. That means after 2 years that you could possibly provide care across state borders with telemedicine, especially to those small incidence rural patients. These are about to expire. And when they do, you may not be able to provide care or at least bill for that care, because the issue has always been that the federal government has no direct licensing authority. So basically you could see VA patients or some specific federal patients, but without reciprocity of licensing. We are about to go back to where if you're doing telemedicine, it may have to be within the state.
Okay, so cross-border, not in-state.
Not in state, correct? Cross-border.
Okay, cross-border telemedicine waivers are going up, are getting shut down. Okay.
Correct. The in-state one was always particularly to the restrictions of the telemedicine, right? Like the patient doesn't have internet access. Can we do it over telephone and bill for that? Those, in my opinion, are going to be here to stay. But the cross-border one, they will ultimately need to be educated by the state level, not the federal level, and no one had sued for it. But I think ultimately we will need something like the nurse licensure compact for physician status.
In the interest of time, how do you regulate that? Because numbers can be from anywhere, everywhere. I mean, if you got your phone in California and you move to New York, you keep that number, right? Same thing. So how do you regulate cross-border?
How do you regulate? I mean, it'll be based on the patient declaration, right? So if a patient says, "Oh, my address is PO Box 52 in New York," I mean, what are you gonna do? Check the ID of the patient to make sure that they're actually a New York resident? Probably not. So I'm sure some people are going to be trying to game the system, but if the address doesn't match or the patient states,
gotcha.
Doc, you're in New York, I'm actually in Florida, then you may start running into issues there.
Sure. Gotcha. We are up for time, Dr. Erdik. As always, very insightful. I think, there's enough food for thought, and, as per wishes, people can go and look up. Thank you for those insights, Dr. Erdik. Sure, absolutely. We now have the pleasure to have Dr. Furkan Tijani, Chief of Cardiology, Director of Advanced Cardiovascular Imaging and Advanced Peripheral Intervention at Century Medical in New York, in Manhattan, with whom we'll be talking about care plan sharing, care gap closure, by diving into some specific cases. And the first case which Dr. Tijani wanted to start with, he told me, was communication or lack thereof. Dr. Tijani, welcome.
Good afternoon. Thank you very much for having me here. I'm gonna talk about, I want to start off by saying, I want to talk about all the mistakes that I've made that I'm proud of. And probably by the end of this podcast, you're going to say this is the most incompetent cardiologist that you ever had on your podcast, because I made a lot of mistakes. The only difference is that making these mistakes, I've tried to learn from them and try to come around to a solution. At least I may not have achieved the solution, but I've at least tried. And when we talk about communications with the patients, you know, there's a wish and a demand that should have been there from medical school, that physicians should have a specific communication classes that teach them how to communicate with patients, how to communicate with colleagues. Because what happens is oftentimes we become so scientifically enamored. We're so scientifically inclined. Patients are so scientifically enamored that they want to hear all of these, this medical jargon that sounds so amazing. But at the end of the day, the communication doesn't happen because you're speaking a language that the patient doesn't understand, and patient is understanding something that they feel very impressed with. And I'll start with the first one. One of my cases where the patient, it's like, has a borderline linguistic capabilities in the language that I was communicating with. And the patient was extremely nice and kind with me, where he did not correct me that it's like, I'm not understanding. Yet, having had mentors in the past who told me, make sure that you make the patient repeat at least the gist of your conversation. And then when I finished my whole about 15-minute long lecture with the patient about all the instructions about the care plan, and the patient says, it's like, doctor, I'm really sorry, but I'm not fluent in English. That was one of the first times when I said to myself, it's like, this was my lack of capabilities in that interview, where I should have early on intervened and asked this patient, do you understand everything that I'm saying? And going forward, one of the things that I've done is, even small snippets of information, I keep repeating. And sometimes patients say, it's like, once you're familiar with, you don't have to do that. But once the early on during the patient physician contact, you should ask the patient, after even small snippets, did you understand what I said? Do you have any questions? And when you start with that, a lot of this communication gap that happens between patients and physicians doesn't happen anymore. The other thing is also, we have, as a specialist, one of my responsibilities is to communicate with my referring physician, and to leave the onus upon either my staff or the electronic medical records that we own, or the system that I have, that all the information is getting to the referring physician, is unfair to them. Because one of the things that happens is, after the patient has had a specialty consultation, most of the times they follow with a referring physician. Early on, and that's been my policy. Most, if not all, of my physicians that I'm referring to, a quick phone call or a text message, especially now with how easy things are, to just let them know what's the most pressing issue that I sent you. Send a message out to this physician. So this is in front of this physician when they see the patient the next time, and it makes life much easier for these referring physicians. And they appreciate it, because now they don't have to find you. And on the day, and especially with somebody who's a proceduralist, I'm not available at certain hours of the day. Now the physician has the patient sitting in front of him, and we will talk about these other things, where he says, yeah, he saw me, he talked to me about it. I didn't understand, or he must have sent you a report. And to referring physicians, I've always felt it's unfair, and we don't, as a specialist, I'm going to say, we don't do enough for our referring physician to get all the information in timely manner. And it is a gap that needs to be filled up, as efficiently as possible.
Absolutely. So population health is about those islands of information that need to be bridged with a boat or a helicopter, and that's where care plan and having somebody who's like an angel looking over the patient, like a nurse, will actually grab those referrals, bring it back to the PCP, and have information that's lying around at home that needs to be returned to the referring physician. But then the next visit for that patient is not in maybe a few weeks. that information is fed back to the physician. This way the physician can actually do something about it if there's a follow-up to do. So absolutely. So you hit it spot on. Communication or lack thereof is a big problem, because time is an issue. I mean, you have X number of procedures to carry out a day, and if there's 1 or 2 patients that need to, refer back to the referring physician, it's hard to keep track of all these details, and that's where population health becomes very much something that covers those areas of those gray areas and make it possible. So absolutely. And to comment on your humility, the person who says he's never done a mistake is a liar. Right?
I guess I tell too much truth.
That's all the credit to you, Dr. Tijani. So tell us about your second experience. You have a couple for us, so tell us.
So one in my practice, or in any cardiovascular practice, or even in internal medicine practice, the blood thinners, there are medicines that have, like I say, there's a level of emergency that is associated with certain medicines, and those are the medicines, not that you take some medicines that are not seriously, but you try to take these medicines as seriously as possible. And one of the things early on in my career, I implemented a policy for the patients where, if you're coming to see me, unless it is physically impossible for you to carry your pills in their bottles, I really want to see them. And you would be surprised how many times you see these patients that have gotten, it's like, Acupril and Fosinapril, or, Lisinopril and Monopril. These are 2 similar sounding medicines, where one person was writing one pill, the other one was writing the other pill. There was no equitable communication between the two parties, and the patient has this. And a lot of times when these things happen, when you have the pill bottles in front of you, the other thing that I try to do is, I always say to my patients, you and I may have 4 visits or 5 visits a year together or more. Let's try to bring one issue at a time, because I'd rather spend a full amount of time for one issue with you than partial for 4 issues. And this way I can empower. And the other thing that I've always strived for is empower the patients, because I tell them, I'm about 5 minutes in a 365-day care package that you're getting. That 5 minutes is not going to make any impact if you don't understand what happened in those 5 minutes. So if I see you 5 times 5, that's 25 minutes. Instead of doing 5, bringing up 5 of your issues, I'd rather, deal with hypertension in one visit, deal with diabetic, hyperlipidemia in the other visit, deal with diabetes in the other visit, to literally compartmentalize your care. Patients actually understand it much better. They don't feel like that there was a time that was, not enough time was spent. And the other thing is also, they're more educated about the care plan. Knowing the medicines and knowing the doses. And, when we came to the smartphones, which is basically every, bar few patients in my practice, everybody has a smartphone. I've either asked them or I've done it for them, where there's a picture of their pill bottle on their phone. Save it in the pictures, make it into a favorite, so it's much easier to actually get to if it's an iPhone. And now the patient comes in, how many medicines are you on? Here are 7 pictures of these medicine bottles that I'm taking. I'm taking this in the morning, taking this in the evening. You never miss these medicines. Hence, and in along the vein of blood thinners, once upon a time it was Coumadin that was one medicine. Now we have multiple medicines. Some of them are to be taken in the evening. Some of them are taken twice a day. Some of them are taken once a day. So having, especially for the anticoagulants, which does represent a fair portion of my practice, and antiplatelets, you need to have the picture of these medicines available to you and the patient's understanding of which medicine they're taking, and also educate them what is the benefit of this pill. Absolutely.
This is so medication reconciliation. That's the bedrock of what population health is about, because all our patients take medication, right? Because in order to qualify in population health, the cost savings program of Medicare, you need to have two chronic conditions. So all our patients have some medication or the other. So yes, so you hit it spot on. As far as blood thinners go, this gets even dangerous, right? Because we are talking about, a patient that's not calibrated properly, and not having to see either provider for a long time gets into the danger zone, where a risk of a bleeding and that sort of situation we want to avoid, of course. So what you do is already very good. I mean, you're asking them to use technology, which is the cell phone, to take pictures and show you exactly what they're taking, instead of showing you with a picture. That is already one step forward. What you can think about where we come in as population health partners is that we will make sure that these types of situations are avoided, where there are two medications of the same type that the patient is taking, just because they're prescribed by two different actors in the chain, if I may say that, because if you look at 4 chronic conditions, you have maybe six physicians that the patient has to see, and not counting the staff, the PAs and the nurses in all those places. So there's a lot of people that come into play, and these are geriatric patients. So these kind of mistakes are so likely to happen. So yes, to keep an eye on medication, if I may say, for cardiology, where just hypertension, we have dozens and dozens of medication, and calibrating the medication and making sure that there isn't patient taking twice the same type or that sort of thing. And of course, if you want to talk about remote patient monitoring, is remote patient monitoring something? Tell us your experience. Are you doing remote patient monitoring, Dr. Tijani?
Yes, I do. Yes, I do.
Tell us your experience with RPM, please.
See, the thing is that a lot of these chronic illnesses have these small signals that start, and if you pick these small signals early on, you're actually able to act on them. It's the classic example is of the heart failure patient, doing the rate monitoring every day. You give them a good instruction about how to tailor the diuretic therapy. These patients could all be avoided from going to the emergency room, because you're somebody who and again, the holiday is going to be upon us very soon. To be an American, we have to have hamburgers and French fries and hot dogs, and then the salt content of these things are through the roof. And my issue with patients has always been, just because you have heart disease or just because you have a chronic illness, you can't stop living. So, but by the same token, instead of being chiding you for making a mistake, I'd rather be a partner in care with you, who basically helps you navigate. So say, for example, you go to a 4th of July party, you had a little bit too much salt intake. Let's talk about how you're going to work through it. And for, as I just said, for the heart failure patients, you have a pound and a half that goes up in weight. If you have a strategy and if you have a management plan that you made and discussed with the patient, these patients on 5th of July or 6th of July at night, in the middle of the night, are not going to be in, rip-roaring pulmonary edema because they had too much salt intake. These are the patients that are actually going to do well. They will increase their diuretic intake. They will limit their fluid. They will, get through it. Their pressure is going to be high for a day or two, but they will get through that without any major problems. And that's where I see, chronic care management for these patients with heart disease and, hypertension, with heart failure. It's a major improvement.
Absolutely. So blood pressure is the bread and butter of what you do, right? Tell us a little bit about how diabetes comes into play in your experience.
Well, diabetes is like, with the hypertension, like I have the trifecta of the diseases. The only problem is that when you have hypertension and you have hypercholesteremia, it's 1 + 1. That's still 2. You add diabetes to it, it's now 1 + 1 + 1, and it could be 5, it could be 7, and it could be 9, because what happens is that all the vascular disease that usually would be going at a snail's pace, or a disease that's going to be of the decades, now becomes the disease of years or 5 years. And by the time you actually have 5 or 6 years, you actually have manifest vascular disease or manifest coronary disease. And that's one of the reasons why my thing has been, you know, pay clear attention to the pre-diabetics. And also, for me, it's always been, there has to be a referral to an endocrinologist or the internist who is managing diabetes. So this way you're not, the A1C is not being, A1C is supposed to be done, 4 times a year, every 3 months, but not just a test that's being done, but this is a test that's being done and followed. But also after these tests, there's actionable items that are being done for these patients. So whether they're pre-diabetic or they're diabetics, they don't end up with all the vascular disease. That is, that's a major problem that we're facing in US these days.
Mm-hmm, mm-hmm. So heart disease, #1 killer in the world, #1 killer in the US. We are looking at obesity, diabetes, smoking, adding a significant burden to what is already a very difficult task. However, that being said, cardiologists have been phenomenal in secondary prevention, so with medication and good care. The secondary prevention has been able to reduce that burden. Now, primary prevention is the name of the game, because heart disease, if you're able to go to the root cause and prevent it in the first place, that is where we will be able to have a significantly more impact. So prevention in the context of population health, we're talking about putting the effort upstream and trying to manage the problem before. So you mentioned about the trifecta, right? Tell us a little bit about how do you see population health and primary prevention, that is looking at the problem upstream, way upstream. How will that be possible? Looking at, of course, the challenges of the reality, right? The reality is that 4th of July is coming up. So people are going to be eating hamburgers like they've never seen one in their life. And so that's the reality, right? And then there's another holiday, and then there's another birthday, and then there's, vacation, and there's this, that. So that's the reality. And how do you see primary prevention? That is prevention before the problem comes. How do you see that impacting the disease?
See, the thing is that every strategy, it doesn't matter whether it's hypertension, whether it's diabetes, whether it's hypercholesteremia, every document that has ever been written in medicine, lifestyle modification is always the first tenet or the first stop. The only thing is that nobody gets off at that first stop, because everybody says it's like, the bus is going further down anyway, and I know that I'm going to be closer to the destination, so why not stay up until secondary prevention? But and I've sort of devised certain plans which have worked for me personally. And when you, for some reason, as humans, we do more out of guilt than we do out of reward. So it's like, when you tell somebody, it's like, I'll do this, and you'll be rewarded. They may or may not do it, but guilt is a very major, it's a very strong motivator. And
sure,
finding the appropriate patients that are at risk, but also being honest about, their genetic profiles, knowing their ethnic background, and then having a very unvarnished discussion about what is the likelihood of their coronary disease, or what is the likelihood of their vascular disease, or what is the likelihood. And one of the words that I always use, remember one thing: when you're dead, you're dead. There's nothing that can be done. But when you're diseased and disabled, there's a major price to pay. Let me be your partner in delaying your disability and disease as much as I can. I may or may not be able to do anything for your death, which basically is not true, because if you have the correct strategies, those people who don't have vascular disease, those who don't have inflammation, do tend to have longer lifespans. But be that as it may, my thing with my patients has always been, let me be a partner in your care rather than a paternalistic care where I tell you what to do and you go ahead and what you do. I want you to be aware of what you're capable of. I want you to feel a little guilty about what bad things you're doing. And then with that, when you're the one who's deciding basically to take care of your own self, and knowing that if you don't do this right, all the bad things that happen in your family may happen to you. You are motivated to do this. And I'll give you, a simple example. It has been over 5 to 7 years that I've sent an uncontrolled hypertension from my practice to a hospital. And the reason is that all of my patients, and I say this with a lot of pride, that my patients are very compliant with their medicines. They're not compliant with my medicines because I'm a good physician. They're compliant with their medicines because the message is clear to them. They know what's at stake, and they also understand what are the benefits of these pills. And in one of the things that I wrote, the blue pill and the pink pill, it's not about the blue pill and the pink pill that they're taking, or the purple pill or the white pill, or the big pill or the small pill. Every one of the medicine is appropriately adjudicated for what it is doing, and also how it benefits them, and also the time when they're frustrated about taking these medicines. I say to them, when you're upset, angry, unhappy about certain medicines, please come to me. Let me walk you through this rather than you trying to do this on your own, because it will be easier for you if you do it with me.
Well, that's fantastic, because yes, the color of the pills, I usually get, I'm like swimming here, because I never look at the pills, you just prescribe them, right? So talking about the modifiers, age, sex, and family history, those you can't do anything about. Those are non-modifiable, but the rest is fair game.
Yes.
The rest is where you can act and you can do something about it. So that's where primary prevention comes in. So regarding, of course, I like to just, place where our role actually comes in. So of course, with the pills and stuff, this is nursing. And our strong point is that we actually staff the practice with nurses. So you have nurses doing chronic care management. This is their bread and butter. This is what they do in and out, looking at the pills, medication reconciliation, communicating that information to the territory liaison who feeds that to the doctor, and of course seeing what the specialist has asked, and feeding that to the doctor, and knowing the specialist, because so there's a regularity. So over a period of a couple of weeks, couple of months, the nurse becomes part of the life of the patient. So the nurse will know Dr. Tejani because the patient has gone already 2 times in a period of three months, right? So, and then that information that you want the patient to have and to carry out will actually be the responsibility of the nurse. The nurse will be juggling that information. So you have one more actor in between the providers. So that makes it, care gaps, closing care gaps. But first of all, you have to have those gaps identified. But this is a very open, very easy one to close, is to have the right medication and the right dose and prescribed. And of course, RPM gives the data. So if the patient is not properly calibrated, we have information that's live, it can be fed either to you or the PCP. So technology has changed a lot. How have you seen your practice transform with technology?
Well, I'm better. I'm better, but also it's like there are certain human touches, and I'll give you a simple example of me walking in the neighborhood to the 3 neighborhood pharmacies that I have. Mm-hmm. And years ago, basically going up to the pharmacist and saying, it's like, by the way, my name is this, I'm here, I practice here. And the pharmacist says to me, it's like, that's really nice of you to come here. Fast forward a decade later, the pharmacists are my patients, and they happen to become one of the major referring sources for me, more than some of my regular referring physicians. But there's a reason here. When you identify a problem, you're much better able to take care of it. And with technology, one of the things that's like, using of the cell phones. And from from a personal perspective, I've never had any issues with patients bringing the cell phones in the consultation room. I would say 95+% of the times, I do not bring my personal communication device in the room for a simple reason. And the patients have said that to me, that we realize you never have your cell phone on you. And I said, because the time that I have with you, you have my full attention. And believe it or not, small snippets like that, they have a major influence on the patients, because patients realize that the physician or the care, the care provider really cares. But going into the technology, I mean, the ability now to identify the blue pill and the pink pill from images of all the pills, and there's always a pill identifier at least on one or two sides of a medicine. I'm not hamstrung by making phone calls and trying to find out exactly what is this pill, because the patient brought me the weekly pill box, which basically has 3 to 4 medicines per box, 2 of them that I know, but the other 2 or 3 that I don't. So I am happy about the fact in the times that we're living in, because it's done nothing but improve and enhance my care.
You have a very nice shirt on.
Well, thank you.
Tell us about surgery.
So my, years ago, I sort of, in addition to cardiac disease, vascular disease was something that I always felt was underreported, underrecognized, under-identified, and undertreated. Because remember, when you go to a hospital, you're complaining of chest pain, there'll be about 6 or 7 individuals of different, backgrounds that will run up to you. There's a nurse, there's an MA, they're doing the EKG. They just want to make sure that you're not having a, ST elevation MI, because they want to keep their metrics at par. But you walk into a hospital saying, it's like, my legs hurt, my legs ache. And I decided to take that path, where my thing was, it's like, there's no reason for a person to have impaired mobility as you get older. You should be able to walk. I mean, barring arthritis, if you were a brisk walker as a young man, you should be a brisk walker as an old man, or a woman. There's no reason why your mobility should change. And going through this pathway, looking at the venous disease, especially in addition to the peripheral arterial disease, I saw that all of these patients were basically just being written off. It's like, oh, don't worry about it. This is just aging process. You're getting old. No, but I used to walk 6 to 10 blocks once upon a time. Now I can only walk about 3 to 5 blocks. Or I used to walk, 15 blocks. Now I get severe cramps in the legs in walking block and a half. And having the ability, and to be honest, to be living in a time where we've made significant amounts of developments, and I've been part of some of the devices that have come to fore in peripheral vascular disease. We have completely changed the face of vascular disease as it is now. The venous disease or the arterial disease, you actually take care of it and you restore mobility back to the patient. Or having patients who had restless leg syndrome for about 15 or 20 years, and this was all varicose veins. You fix those varicose veins, and the patient comes back and says, this is weird. I don't have restless leg syndromes anymore. I mean, I've had patients who started wearing, ladies who started wearing pants because they felt that their legs became unsightly, pick up their skirts that they had put away in their closets for over 20 years, although they're not fashionably accurate anymore. But by the same token, she comes so happy and she says, it's like, look at me. I finally have ankles after all these years. So it's all about, for me, as I said, every visit with the patient is about, I don't care which mood you come in. Mm-hmm. My goal is, when you're walking out of my office, you have to have a smile on your face. And doing that, and I tell patients, it's like, I try to heal you, I try to help you. I'm a partner in care for you. So having the vascular disease has been a major driver in the satisfaction that my patients have with my practice.
Absolutely. A happy patient is very likely to be a healthy patient. That's for sure. We are running pretty much out of time. So absolutely, my background in cardiac surgery, was learning how to put LVADs. But then we put so many LVADs. But the idea is to catch those patients upstream before they need LVADs, right? So that's where population health can actually, maintain those patients that maybe, would really go down that path, and we're able to keep that equilibrium, which is very fine and kind of in a constant, flux. But still, we buy some time, we buy sometimes a lot of time, and maybe, that option of going downhill and, needing a very extreme type of intervention is avoided. So primary prevention going forward is going to be extremely important if you want to get a hang on this epidemic of heart disease. And the second one, they usually alternate. They say, cancer is going to take over going forward. But it's going to be a tough one with heart. So we'll have the chance to come back and talk more, Dr. Tijani. This has been a pleasure to have you, and I want you to know that this conversation about care gaps and care gap identification is an ongoing one. So we'll have the chance to go back to this in the future, and we'd love to have you again on the show.
Thank you very much.
And for viewers, please join us in 15 days at the same time for another podcast. And please watch the replay after it's posted. Until then, I am Dr. Avinash Jaiswal, Chief Medical Officer of CCM Health. And that's it for today. Have a good rest of your day and stay safe.
Thank you.
Bye-bye.